welcome audience and the chairperson, sir. I'll be talking about the talk on antimicrobial stewardship in surgical practice. What I'm going to do is I'll talk about the principles of surgical prophylaxis, antibiotic prophylaxis. I'll give some principles of AMS as such. Then I'll like to take you through the experiences at two of the institutions which I've worked. I will take you through the two of the institutions which I've worked recently, and not recently, last 20 years, and then what is the way forward and the barriers in antibiotic prophylaxis by the surgeons. Right? So, multiple surgical prophylaxis, we require a multidisciplinary teams, includes the surgeons, infection control specialists, and most importantly, the microbiologists, and along with that, the pharmacologists and all that. And we have to follow the evidence-based practice in the surgical prophylaxis. A lot of guidelines are available. I will go through them, touch upon them shortly. And we have to make our this thing. Thank you. So that's it. And not only that, whatever we follow has to be cost effective, keeping in mind our social and status. Oops, sorry. So principles are that before we talk about the AMS, we have to realize, that will be better. We have to realize that antibiotics alone are unable to prevent surgical infections. As a surgeon, we have a lot of other responsibilities. We have to take the infection prevention and control strategies during the hand hygiene practices, which many of us forget while we take. We know about them, but we forget. We have to have meticulous surgical techniques and minimization of tissue trauma. Hospital and operating room environment control has to be there. Instrument sterilization practices and all that. Perioperative temperature, fluid electrolytes, oxygenation, glycemic control. We are all aware of that, but practice is very important. Initially, we have to start the empirical therapy according to the local national guidelines or whatever is available. We have to de-escalate the therapy based on the culture, etc., and the physiological condition of the patient, like renal function, etc. Therapeutic drug monitoring may be used sometimes. But the most important is that whatever national or international guidelines we follow, we have to develop our own antibiotic policy, institutional antibiotic policy, which can be followed depending on the cultures available at the institution. We can't depend on the national guidelines available. So we have to form that. So in the brief, if 3 sentences I have to say for the surgeons to follow is, before therapy, we should treat only the patients who are truly infected. There is not much role of empirical therapy. During the therapy, we should avoid use of combinations when only one agent suffices. That amounts to irrational use of antibiotics. And finally, at the end of therapy, by treating the patient only for as long as required. These are the goals of antimicrobial stewardship program. I will not go into details because of shorter time, sir, to cut down. We all know about them. And core elements are, we have to start from anywhere, and they're all interlinked. Okay, so we'll go with the prescribing antibiotics only when they're truly needed, then prescribing appropriate antibiotics with adequate dosage and appropriate period also. We can't be short, duration, etc. Reassessing the treatment at predefined intervals for de-escalation. Supporting the surveillance. This has to come from the top administration. We have to have resources. I'll touch on this. Educating the staff, one of the most important thing, which is inadequate in many instances, and supporting an interdisciplinary approach. Also, same thing appears for that, for surgical prophylaxis. So, in short, in surgery, we have to enhance infection control, prevention control, prescribe antibiotics, and one of the points I wanted to point out was controlling the source of infection before we embark upon the antibiotics themselves. If we do a fishbone analysis of the SSIs, that is the most important thing, the pre-op factors, peri-operative team factors, organization management factors, and all that. I am concentrating on the surgeon's factor here, lack of redosing, use of staples, poor surgical techniques, we have to be careful, etc. Now, we have to, as interventions, we have to go for we have to find out clinical champions. This could be the leadership, and I believe personally it has to be the leader of the surgical team which has to take the lead, because you can't delegate it to somebody else and expect the results to appear. Unless you are involved personally, it doesn't happen. Engagement of the different members of the patient care unit. Existing infrastructure has to be used, especially EMR. Digital technology helps a lot in anti-AMR practices, and alerts, etc. we can do. And dissemination policy, education, and periodic feedback to the providers to achieve the sustainable effects. Oops. Newer technology like AI and supervised and unsupervised machine learning tools can also be helpful in this. CDSS has come in a big way to help our AMR practices. Oops. After we have implemented the AMR practices, we have to sustain them, and that includes the universal antibiotic policy. There has to be collective responsibility. We may try use of incentives. Actually, in the government sector and private sector, there's a difference between the two. In government, we can't give really financial incentives to implement that. Then backup has to be required. Availability of microbiology culture facility has to be there, and there has to be robust feedback mechanism which has to be given to the stakeholders. These are challenges: lack of interdepartmental coordination, minimal support facilities, time constraints, absence of a champion, competition among doctors, and utility value of antibiogram, which is less understood by the clinicians than it should be. These are the root causes of inappropriate implementation of surgical antibiotic prophylaxis. Again, I would like to point upon the human factors and the surgeon factors, because rest we all know. The surgeon is the main person I'm concentrating today in our surgical practice. Many of the senior surgeons are difficult to make them to unlearn and then learn again. Most of the practices are by experience, which has to be unlearned at many times, and then they have to be trained again. And many of them are of the opinion, keh diya to keh diya, like whatever I said is the final word. This has to be broken and revised. So these are the reasons for inappropriate use of antibiotic in surgical practice: unclear surgical infection guidelines, non-compliance within the guidelines, suboptimal cooperation of the surgical and the antibiotic stewardship teams, underutilization of laboratory by surgeons, depending on the personal experiences, rigid hierarchy of surgical teams. Whatever the senior has said has to be followed. You can't try out your own ideas or the guidelines. Antibiotic prescribing is delegated to the juniors at majority of times, which has to be corrected. Again, causes of, in a graph chart, if you do a Pareto's chart, majority of the things appear to be fear of SSI. Now, this is the example which I want to give in my own institution. I'll touch on it very shortly. So, how antibiotics are chosen many of the time by surgeons? By conformism. What my head has said, I will follow that. Experience of the senior surgeon, antibiotic resistance, lack of trust between doctors and patient, you have to give it to them, and promotional activities by the pharmaceutical agencies. Market forces do affect our practices. And this is, in a nutshell, the effects of choosing a wrong antibiotic at a wrong stage and their effect. I will not go into details of this. Now, India journey into antimicrobial stewardship that started in 2000. Oops, sorry. I have to. It doesn't move. Actually, I have to control it. Okay. So India has been dependent upon the international guidelines most of the times. We have WHO, CDC, NICE guidelines, SHIAR, IDCC, and many others. But in India, the real thing started in Chennai when we had the Chennai Declaration. When we had the Chennai Declaration, a roadmap to tackle the challenges of antimicrobial resistance. Dr. Ghafoor, I think, is in the audience, maybe in downstairs in the hall or somewhere. So he led the group, and we came out with certain recommendations to all the government agencies to implement AMR practices in India to reduce the infects. In the government, we have the ICMR treatment guidelines where they are regularly updated. We have the National Action Plan on AMR, which is as late as 2024, and it's a very good roadmap. And we have standard treatment guidelines and many others which advocate antibiotic AMR practices amongst the surgeons and other clinicians as such. In our participation in AMR activities has increased, and these are bibliographical and representation of surgeons from India, and we are at number 9 in this analysis regarding the publications, etc. in the AMR. Now I'd like to touch shortly upon 2 institutions I've worked. One is the Chacha Nehru Chikitsalaya. It's a pediatric hospital in Delhi, of which I was 13 years and I was director 5 years. And Lady Hardinge Medical College, which is over 110 years old hospital, where I'm currently working. So CNBC was established in 2003. It is the country's first NABH accredited public sector hospital, which had a very good systems. We had the policies, etc. were in place, and we could do all the what is required for AMR practices. CNBC, Lady Hardinge, established in 1916, arguably one of the oldest medical institutions in India. It had the old infrastructure. Now, last year we have moved into new building, which has new OTs and all that. Otherwise, there were 100-plus-year-old infrastructure was available. So we had difficulty in implementing our AMR practices because infrastructure was not there. Faculty was senior. Difficult to model them into or make them change their minds. That is the most difficult thing actually. For any quality initiative, change of mindset is the most important thing. If we do that, and policies and practice was not well developed. CNBC, we started from the beginning. We started antibiotic AMR policies. All the clean surgeries, starting with the hernias, hydroceles, and other superficial things, we were doing without antibiotics and without any adverse outcomes. However, in Lady Hardinge, we had difficulty for the reasons I just said. So to encourage my colleagues to implement AMR, I took on 2 projects, gave the thesis to my postgraduates. First was SSI due to accidental spillage of bile. Regular practice was to, if the bile leakage has occurred, I would give antibiotic for 7 days. But we started without any antibiotics, do a proper lavage and follow them up for up to 30 days. And we did not find any adverse effects of not giving prolonged antibiotics after accidental bile spillage. Encouraged by this result, my thesis which just completed, PG thesis completed last month, was we did low-risk lab colis without antibiotics. Earlier we were giving only single-shot prophylactic antibiotics. Now we did lab colis without antibiotics. So there were low-risk identified cases in which there was no comorbidity, diabetes, etc. And we did 100 cases, and there was no SSI in either of the groups. Right? 50 we did antibiotics, 50 we did that. So we have shown by our experience that antibiotics are not required, and as is mentioned in many international guidelines also. So our results, provided we follow the basic principle of surgery. So this is what I wanted to highlight here. So road ahead means we have to empower, everybody has to be empowered in the role, even the juniors. Nurses play a very strong role. They have to be empowered, and empowerment will come for that. Prior to that, we have to have knowledge. Once we impart them training, we impart them knowledge, we can empower them. They can control the surgeons, and that's what empowerment is. If we write an inappropriate antibiotic or we are breaking the policy, they should be empowered to correct the surgeon actually, which is a tough nut to crack frankly speaking. So this is what I plan to do now. After going back, in fact, we have created our new antibiotic policy, which was sketchy at the most earlier. Now we have created a new antibiotic policy. And this is a standard Ishikawa chart, which is a PDSA cycle, which I propose to implement shortly after going back. And we can't forget the role of patients, who are the major stakeholders. We have to educate them on antibiotic usage. 5 moments of medication safety, especially with reference to antibiotics, has to be percolated down to the user himself. And they should be able to ask questions, why I am being given antibiotics? Unless this happens, our surgeons will be difficult to control actually. Thank you for your patient hearing.
Thank you, sir, for that presentation. And very interestingly, in the era where many of surgeons still practice to give not just a prophylaxis first dose of antibiotic, but continuing them for a day or two, and sometimes also discharging on oral antimicrobials is not uncommon. So I think many of the audience here will agree with me that it's not an uncommon practice, that we do see that the elective, low-risk surgery, I'm not talking about a complicated, spilled or a contaminated surgery, are getting discharged with oral antibiotic. Whereas something else has been spoken today. We are talking about a low-risk, laparoscopic guided surgeries without any risk of infection, on antibiotic prophylaxis, without antibiotic prophylaxis. Something is an eye-opener. You probably don't need an antimicrobial prophylaxis. Something has been reflected onto us. In 20 years back, when we were practicing critical care medicine, anybody who was required an endotracheal tube, anybody who required a central line, anybody who required a Foley's catheter, the concept was these patients needed an antimicrobial prophylaxis. Today's era, none of our patients on endotracheal tube for a non-infective reason, a central line for a non-infective reason, doesn't receive any antimicrobial, and there is no difference between those who are on antibiotic, those who are not on antibiotic. And that is the change we have made already in ICU, and something which is opened up is in the OTs. So we have some questions. Can somebody give a mic to there? You have any questions? Any audience questions? So that was actually very interesting, sir. But I just wanted to ask you, as a head of chairman of Lady Hardinge Medical Colleges here, I understand the public and private component, and you said the incentives, appreciations, and giving priorities, or maybe giving some kind of appreciation to them is a challenge. But how do you handle your surgical teams in discontinuing, not using prophylactic antibiotic? What is the key?
That's what it is. So I started this project with my unit actually. And now I have shown them that it can be done. So now it has come into my antibiotic policy also, of which I am the chairperson of my AMSP committee also of Lady Hardinge. So I have included that, and now it seems to be PDSA cycle, which is the chart I showed later, that now I want to educate them, train them, and encourage them not to use antibiotics. So this is the next step actually.
So I think if what message is giving is, if the senior most surgeons, the person who has been looked at, if he start the practice, we had a discussion with Dr. Ligaya being there and some of our senior administrators be there. If the administrators start accepting and taking actions on that angle, seniors follow that, I think the lower down track automatically will fall in line, and probably that is the way forward, to start with the top guns and then follow that.
So that happens, that's what I mentioned in quality. It has things start at the top, not it's a bottoms up approach. Nahi hai. It has to be at the top. If he is involved, things will happen. Like quality again, AMSP, if it has to be successful, head of the institution has to participate in that.
So I just wanted to conclude this session by one line. If your tissue handling has not been appropriate, if your surgical asepsis has not been appropriate, if your OT infrastructure is not adequate, no matter what amount of antimicrobial will push, you name it meropenem, you name it polymyxin, you name it ticoplanin, you name it
something else antibiotic, the patient in post-operatively will get candida. If you give candida treatment, he will get into something like aspergillosis. If you cover with voriconazole, you will have a selection pressure, you will get mucor. So don't try to treat with antimicrobials by not following appropriate asepsis and the basic things first. In my experience, has shown antimicrobial does a collateral damage. It should be appropriately used when there is an indicated. Preventing infection by using antimicrobial is, I think, slowly has to be taken out of the box. You have to probably improve your... Yeah, ma'am. You have any question? Yeah, please.
Yeah.
Sir, as a dentist, when I was in my final year, as you said, we prescribe prophylaxis first line as antibiotics. Even in education, I think we are told, like basically while we do extraction, after extraction, we are told to give antibiotics no matter what, even if the infection is not that much. Because if after extraction, if it's a minor infection, after extraction itself, the infection is gone. But I think one of the reason might be like that even after empowering, like there are the protocol to tell after extraction to the patient what are the do's and what are the don'ts. Still many patients come after, like even if we told them you get the pain, don't apply balm and anything, but still they do, because in public sectors like public hospitals, unprivileged people generally come. So even after empowering them, they do this and come with the swelling, which is like we need surgical intervention. So because of that, even in education system, we are automatically told, no matter what the infection is, like less or more, we have to prescribe antibiotics.
We take that point. See, as we move forward, dental extraction, simple procedures may not need a prolonged antimicrobial therapies or a prophylaxis. With the